The Knowledgeable Provider podcast is educational, entertaining, and not the same as medical training. The information presented here should not be used by anyone to diagnose or treat any medical condition in themselves or others. If you need medical advice, go see your own knowledgeable medical provider. Opinions expressed on the podcast are solely those of the people expressing them and are not necessarily representative of any other entities. Other than lunches at the office, I do not receive any sort of compensation from pharmaceutical or medical device companies, and I have no other relevant financial disclosures. It's all fun and games until someone gets sued, am I right? Okay, on with the show. Hello, welcome back to Knowledgeable Provider. I'm your host, Jody Marks. I recently attended the Huntsville Hospital 2025 Cardiology Update held at the UA Huntsville College of Nursing. Last year I did a recap episode on the cardiology update. It was actually one of the more popular episodes, so obviously I'm going to do that again this year. It's a neat little class that's put on by the Heart Center in Huntsville, and they just have sort of a random smattering of cardiologists that work for the Heart Center come and talk about various topics. It's a cool thing. Got to see some old friends, including friend of the podcast, April Clark, who now works for cardiology. She left the emergency room, believe it or not. I don't know how the place is still standing. So anyway, here we go. Our first speaker was Dr. Karen Firth. She is the Dean of the College of Nursing there at UA Huntsville. She mentioned that this is the 50th anniversary of the College of Nursing there at UA Huntsville. If you're interested, there's going to be a Golden Gala on Saturday, April 5th, 2025, to help them raise money for some simulation equipment that they want. I'll put a link to the website where you can register for that if you're interested in the show notes. She also mentioned that they're working on adding a CRNA program. Currently, if you want to do CRNA, I think the closest places to here to do it are UAB, or there's a little school up in Tennessee where you can do that. And Huntsville Hospital also has a partnership, I believe, with Texas Christian University. So there are a few options in the area, but that would be very cool if UA Huntsville would add that program. Man, if I could rewind my whole career, I think that's probably what I'd go toward. CRNA is such a freaking cool job. They make a lot of money, but alas, what can you do? We heard from Dr. Carl Gessler, who's been a cardiologist around here for 100 years. He was one of the founders of this cardiology update. He seems like a really nice guy. I've been around him a little bit. I believe he's still seeing patients. He still sees some of my patients, at least. I get the vibe that he's more into kind of local politics kind of scenes. He got up and spoke and really just talked about him being on the boards of things and made a big point of basically taking credit for getting the money for the College of Nursing building at the University of Alabama at Huntsville. I keep waiting to see that he's running for office. The first speaker about a clinical topic was Dr. James Murphy, also has been a cardiologist around here for 100 years. Super nice guy. I think he was the only doctor that got enthusiastic applause even just walking up to the podium to start speaking. His topic was pulmonary hypertension, and this is something that I'm sure goes undiagnosed, especially in primary care, because it's a little bit tricky to diagnose, at least compared to hypertension, where you just check somebody's blood pressure in the office. You can get an idea of the pressure in the pulmonary artery from an echocardiogram, but really the gold standard for diagnosing this is a right heart cath. EKG is not super helpful for diagnosing this. Sometimes you can see right ventricular hypertrophy pattern on the EKG. He talked about it being important to distinguish between pre and post capillary pulmonary hypertension. So, the blood comes out of the right ventricle, goes through the pulmonary artery, down to the arterioles, then down to the capillaries in the lungs, and then goes back through the venules to the pulmonary vein. And so you can have pulmonary hypertension that originates before the capillary or after the capillary. And you can also have a situation where you have both, or mixed disease. So the definition of pulmonary hypertension is mean pulmonary artery pressure greater than 20 millimeters of mercury. And of course, if the pressure in that artery is high, that means you're putting more strain on the right ventricle, and eventually that's going to lead to right ventricular failure, aka cor pulmonale. The specific diagnostic classification he mentioned was the 2003 WHO pulmonary hypertension criteria, and I will put a link to that information in the show notes. Locally, Dr. Murphy was saying that a lot of pulmonary hypertension is caused by using cocaine or methamphetamine. I know of taking care of patients on the ambulance who had heart attacks after using cocaine. He said that can happen after even 3 or 4 months of using those kind of stimulant medications. I guess I would have assumed it would be caused by really long-term use, but I guess it doesn't really take that long. Often it takes about 1.5 years to get a diagnosis of pulmonary hypertension, and that tends to be even longer in younger patients because, again, it's not super easy to diagnose. A lot of times the initial symptoms will just be kind of vague, mild, like cough, maybe a little bit of shortness of breath, A lot of times it's mistaken for COPD or asthma, sleep apnea, or even being secondary to obesity or deconditioning. And a lot of times, unfortunately, people don't really get sent down the cardiology route until they actually have signs of heart failure, right ventricular failure. So obviously the goal would be to try to pick up on this earlier. And I will say, just when I'm seeing patients, if someone complains of a chronic cough or shortness of breath like that, that doesn't seem like an acute heart event, pulmonary hypertension is probably not something that's in the front of my mind either. I probably would mistake it for asthma, COPD, deconditioning, etc. He mentioned a specific mutation in the BMPR2 gene, which stands for bone morphogenetic protein receptor type 2. Mutations in that gene are the primary genetic causes of pulmonary hypertension, and I'll put a link to a paper about that in the show notes. He said a couple of times that syncope is a very critical symptom. If you are starting to pass out because of late effects of pulmonary hypertension, that means you have advanced right ventricular failure. So syncope, always a red flag, I think, in any situation. As far as clinical signs that you might pick up on listening to heart sounds, it's common to hear an accentuated P2 heart sound at the apex. So that's the sound we're hearing when the pulmonic valve is closing. Obviously, there's more pressure in that artery. The valve's going to slam shut harder. You can hear other murmurs. He mentioned an S3 that gets louder when the patient takes a deep breath. And also, of course, jugular venous distension if we've made it to right side heart failure. He talked about the influence of hormones and chemical mediators produced by the endothelial tissue in the pulmonary artery in response to the higher pressure. You actually get the situation where the blood vessels get thicker or hypertrophy over time. Eventually, they form these things that kind of look like tumors. They're called plexiform lesions. He showed some pictures of that. So if untreated, the pulmonary artery, the right atrium, and the right ventricle will all get larger over time. And obviously, we see that on the left side of the heart when we're talking about effects of systemic hypertension over time. So it's the same kind of thing. Medicines that tend to be helpful include prostacyclin, endothelin receptor antagonists, nitric oxide. He mentioned that if the pulmonary pressure is responsive to nitric oxide, that's a really good prognostic sign. Also prostanoids. He mentioned a new medication called Adempas, Adempas. Generic name is riociguat, Riociguat. I guess most people know that the PDE5 inhibitors that we think of being used for erectile dysfunction were originally developed to treat pulmonary hypertension, and those are still used for that at higher doses than what we use for erectile dysfunction. I had a patient that managed to get his hands on some of that, like, not for me. I don't know where he got it, but he was taking these, I want to say it was like 60 or 80 milligram tablets of tadalafil. I don't even see that it's made in that. I don't know. That must have been maybe that was some fake thing that he got at a gas station or something. Also, one interesting thing that's happened is we had to update our drug database at work just with our particular EHR. And now, for whatever reason, the tadalafil and sildenafil, when you go to prescribe them, the way they're in the database, they have a little parentheses next to them that says pulmonary hypertension. And we've run into issues with freaking insurance companies going, oh, no, it says pulmonary hypertension. We're not covering it. And it's like, oh my God. Anyway, I've gotten way off track here. Back to the new medicine, Adempas. This would take the place of a PDE5 inhibitor. The mechanism of action is guanylate cyclase stimulator, which works by sensitizing and stimulating binding of soluble guanylate cyclase to nitric oxide, which eventually leads to vasodilation. That's an oral medication that looks like it's dosed 3 times a day, so that would be kind of a pain for patients. Currently restricted distribution in the United States, so I'm guessing we're not going to see a lot of that anytime soon. It would be interesting to know if that works for erectile dysfunction like the PDE5 inhibitors. Dr. Murphy mentioned that calcium channel blockers are not especially helpful for pulmonary hypertension. He said they tend to be effective and work for about 3 months and then they stop working, so he doesn't tend to use those for treatment of pulmonary hypertension. He mentioned several relevant tests when we're working up these patients: pulmonary function testing, VQ scan. He said it's actually pretty common for people to have the occult pulmonary embolism. I've learned about that before, and maybe I've even talked about it on the podcast. It's called CTEPH, CTEPH, which stands for chronic thromboembolic pulmonary hypertension. But just important to keep in mind that people can have chronic PEs. I think we tend to think of PEs as being more like a, hey, this is going to kill you right now kind of thing, but it can turn into a chronic condition that leads to pulmonary hypertension. And so if you can get in there and get the clot out, you can fix the pulmonary hypertension. He also mentioned sleep studies, HIV serology. Apparently it's more common for people with HIV to have pulmonary hypertension. He mentioned autoimmune serology, ANA, and rheumatoid factor. I would assume that having higher levels of inflammation would make you more prone to having a clot or having pulmonary hypertension. And then, of course, again, the right heart cath is the gold standard for diagnosing this. He mentioned that cardiopulmonary exercise testing is not super helpful for diagnosis, but it is a good way to monitor people long term. He mentioned a particular risk score calculator that would be the 2022 ESC and ERS3 Strata Risk Score Calculator. ESC is the European Society of Cardiology. ERS is the European Respiratory Society. That looks at 10 different parameters, which include clinical signs and test results, to give you a low, intermediate, or high risk score to think about whether somebody might be at risk for pulmonary hypertension. And I'll post a link to that for you. The next presentation was from Dr. Jose Cavo. He talked about cardiogenic shock. And this was really just a very basic physiology kind of presentation. I don't remember him talking a whole lot about management. And it felt like maybe it was the wrong audience for this kind of talk. I think it would have gone over better with students. It seemed like everybody in the room were mostly nurses or nurse practitioners, and there were a handful of cardiologists also. And most of them, it seemed like, probably work in critical care. So these are people who already definitely know about cardiogenic shock. I just got the feeling in the room that it wasn't super well received. Nobody asked him any questions when he was done. And I didn't take many notes. I guess I didn't really get a lot out of it. One thing he said that kind of made me think was the heart generates blood pressure but doesn't have a role in controlling it. And that's interesting. If you think about it, everything that kind of regulates the blood pressure has more to do with kidneys and muscles that regulate vasoconstriction, vasodilation. Of course, the heart can change its rate and its contractility, but that all happens in response to signals that come from outside the heart. So that was a pretty interesting statement, I thought. He mentioned that it's not a good idea to use beta blockers for acute decompensated heart failure. Because if you think back to that very basic equation about cardiac output being the product of stroke volume and heart rate, you need that higher heart rate to maintain cardiac output when your stroke volume is diminished. So lowering that rate is not a great idea. Of course, we do think of beta blockers as being a treatment for chronic heart failure. That's one of the 4 pillars of the GDMT, guideline-directed medical therapy for heart failure, but not so much in the acute setting. Another interesting thing he said was that one presentation of cardiogenic shock may be abdominal pain because the abdominal organs are not being adequately perfused. And so a lot of times these people will kind of go down the abdominal route. They'll get abdominal imaging before anybody realizes that their heart's not working. The next presentation was by Dr. Daniel Sidedo and Dr. Kanya Singapadki. Apologies if I mispronounce those names. They are both pediatric cardiologists. The Heart Center actually has a pediatric cardiology clinic now, which I did not know. For a long time, Dr. Israel was kind of the only game in town for pediatric cardiology in Huntsville. But now the Heart Center has that available as well. Very cool. They tag teamed this presentation and both spoke very, very quickly in thicker accents. So I might have missed more from this presentation than any of the others, but I feel like I also got more out of this presentation than any of the others. A lot of what they talked about was non-cardiac causes of chest pain in kids and adolescents. I'm sure we've all taken care of the young person, the teenager, or the 20-something adult who comes in with chest pain. Of course, in the back of your mind, the very first thing you're thinking is anxiety, or at least this is not heart. I used to tie myself in knots about this when I was a paramedic because our protocols really did not make any distinction between old people with chest pain and young people with chest pain. And so really, by protocol, you're supposed to give aspirin and nitro and treat everybody as if they're having a heart attack if they're having chest pain. Or at least that's how it was back in the day. And so it always created this weird, like, almost cognitive dissonance or something where, like, okay, I know that it's not necessary to give aspirin and nitro to all these young people having chest pain, but if I happen to be wrong, if this is the very rare young person having a heart attack and I don't do what I'm supposed to do, I'm hanging myself out to dry. And oh man, I used to go back and forth. Sometimes I would call the doctor and ask for orders not to give the aspirin and nitro. Sometimes I would just give it even though I thought it was stupid. And sometimes I would just not give it on my own and then feel scared about it. Oh, it was always such an anxiety-provoking thing for me. So anyway, I'm going to say Dr. C and Dr. S. Dr. C and Dr. S said that most chest pain in adolescence ends up just being idiopathic. Cardiac causes are less than 5%. Dr. C made the point that young athletes have about the same chance of dying from a heart issue as they do of getting struck by lightning. They went through a bunch of other things that can cause chest pain in adolescence more commonly than a heart issue. The first one was costochondritis, which of course is just inflammation in the connective tissue in the rib cage. A lot of times that happens after a person has been more physically active than they usually are, or after a recent viral infection. And a lot of times you can actually reproduce that pain by doing sort of a rocking motion lateral to the sternum when you're examining the patient. He talked about precordial catch syndrome, which is also known as a Texador twinge. That sounds like a drink you'd order at a country and western bar, or a line dance maybe. Ernest Tubb and the Texador twinges. Anyway, that's really all it is just a sharp, very catchy, catch-like chest pain. Don't know what causes it, but we know it's benign. The next one is slipping rib syndrome, which is caused by trauma to the lower ribs, specifically numbers 8 through 12, that results in irritation of the intercostal nerves. The next one is Tietze syndrome, Tietze syndrome, which is where you get inflammation of a single costochondral junction, and that usually is preceded by a viral infection. Hypersensitive xiphoid syndrome. I definitely have seen people that have pain in their xiphoid process for no apparent reason, or people who lose weight and then become aware of their xiphoid process and think it's a problem. Of course, with kids who are really tall and thin or have connective tissue disorders, you have to worry about pneumothorax, spontaneous pneumothorax, and pneumomediastinum. Pulmonary causes of chest pain can be asthma, pneumonia, bronchitis or tracheitis, foreign body aspiration, pulmonary embolism, or pulmonary hypertension. GI causes can include acid reflux, pill esophagitis, gastritis due to NSAIDs or aspirin use, and esophageal rupture, also known as Borhave syndrome. Yikes. Psychogenic causes, of course, anxiety was the first thing I mentioned a few minutes ago, and that's probably always the first thing that pops into my head. Obviously, that's a diagnosis of exclusion. You have to rule out all the scary stuff before you can really say it's due to anxiety. It bothers me when people jump to the anxiety thing. Even if that's what you're thinking, that has to be the last thing on the checklist, right? You don't just automatically assume it's anxiety. They mention acute chest syndrome that happens with sickle cell patients, breast masses, scoliosis or spinal nerve root compression, intercostal neuralgia that comes from chickenpox or shingles. Then they got into some more cardiac causes of chest pain in adolescence. You have myocarditis or pericarditis. A lot of times with that, you have some kind of preceding illness, and that tends to present with sharp pain that radiates to the left shoulder. Gets worse when the patient is laying supine. Sometimes you can hear friction rub or muffled heart sounds on exam. Things that cause obstructions of the left ventricular outflow tract, for example, hypertrophic cardiomyopathy or aortic stenosis. Abnormalities of the coronary arteries, which can happen with Williams syndrome. You can have AVMs that form in the coronary arteries. There's a situation called a myocardial bridge, where instead of the artery kind of laying on top of the heart muscle, it actually dips down into the myocardium. And then connective tissue disorders like Marfan syndrome or Turner syndrome. Indications for sending a young person with chest pain for an echocardiogram would include if they have some kind of weird heart history themselves, if there's a strong family history of early cardiac death, or of course if they have any abnormal EKG changes or concerning physical exam signs that make you think this is a cardiac problem. One thing that came up that I had not thought about is that when you're talking about adolescents, chest pain at rest is actually more reassuring than pain with exertion. I think we tend to think the opposite in older people, right? Stable angina that only happens with exertion is better than unstable angina that just happens randomly. But with a kid, with a young person, you pretty much know that chest pain is not caused by coronary artery blockage like with old people or any other cardiac cause. But if it was a cardiac cause, it would be more likely to get worse when the heart is working harder. So in kids, it's actually a good sign if they have chest pain at rest versus with exertion. The next topic they covered was syncope. Again, this is specific to adolescents, kids. Of course, very rarely is it due to a cardiac cause. If it does have a cardiac cause, it's more likely to be like a life-threatening kind of situation. The top 3 causes of syncope in kids are vasovagal, idiopathic, and POTS, which is postural orthostatic tachycardia syndrome. I think that's something that's way underdiagnosed. POTS or dysautonomia. I'm making an effort to send more people for testing for that because I think it's something we miss a lot. They made the point several times that if a kid passes out after exercise, so if exercise precedes the syncope, that's a very concerning sign. You got to take that more seriously. If there was some kind of acute arousal or loud noise that happened before a syncopal episode, that actually points toward long QT syndrome. So that would be a situation where you might want to err on the side of doing an EKG. If they have palpitations or chest pain before the syncope, of course, that's more concerning for a cardiac cause. If they lose bowel or bladder control during the syncopal episode, then that's more likely to be a seizure. if a lot of preceding symptoms come before the syncope, so they get tunnel vision and get dizzy and feel short of breath and feel hot and all these different things that people say, that's more likely a vasovagal situation. Or of course, if it's caused by body position changes, that's more likely to be vasovagal. One of the common things that we do when we're assessing syncope patients is take orthostatic vital signs. They were saying that that's probably not really as helpful as we would like to think. They said about 40% of kids will have those changes that we're looking for just on a good day at their baseline, and it doesn't mean anything. And they said probably that's true for a lot of adults also. They talked about breath holding. So like the kid just holding their breath, not breathing for a while. It's common in little kids like 6 months to 2 years of age. A lot of times it's triggered by some kind of emotional insult, pain, anger, fear. It's a benign thing, but it's scary. They showed a video of a really small infant doing breath holding, and he said the big sign you can pick up on is that it looks like the child's crying, but you can't hear any noise. And in this particular video, the baby didn't breathe for a long time, and that's what it looked like. The kid would look like they were crying and upset, but you couldn't hear any sound, and that it turned blue. It was like crazy looking. Obviously would be scary for a parent or even a healthcare person. But again, that's a benign thing, and it usually stops by itself by age 5. But yeah, if somebody told me that their kid quit breathing and turned blue, I definitely would not immediately attribute that to benign breath holding. I think that would send me way down the cardiac path to rule out some kind of congenital heart thing or whatever. They talked a little bit about why the QT interval is different for kids versus adults. Around puberty, you see changes in the QT interval that are normal just as the child grows, as the heart grows. So that makes sense. In kids, the most common cause of pathological long QT syndrome is genetic mutations in potassium and sodium channels. He mentioned that beta blockers and also sodium channel blockers. The example he gave was a medicine called mexiletine, mexiletine, which maybe I'd never heard of before. The most common cause of the rare situation where the young athlete does drop dead from a heart issue is hypertrophic cardiomyopathy. I always think about this when I'm doing sports physicals for kids. I always try to be real careful listening to their heart because I don't want to miss any kind of heart murmur that I might have been able to pick up on. They mentioned that Ehlers-Danlos syndrome is kind of like a viral social media thing right now. I guess somehow it's been made popular on TikTok or whatever, and there are a lot of people coming in wanting to be tested for that. So it's something to keep in mind there. The last session of the day was a really interesting panel discussion. So they had a general cardiologist, Dr. Christopher Roth, an interventional cardiologist, Dr. Clarence Gill, and a cardiothoracic surgeon, Dr. Andre Samayoa. And then Dr. Jacqueline Green, who's also a cardiologist, was kind of the moderator of the discussion. She was actually the host of the whole thing, the moderator for the whole thing. She did a presentation last year on cardiopulmonary exercise testing that was really interesting, but she didn't present anything herself this year. But anyway, they basically just had a discussion where they went through some different cases, and you just sort of got to hear the dialogue between the three subspecialties about how do we make the decision of if we're going to go to the cath lab versus if we're going to do a bypass surgery. And it was just really interesting to hear that thought process, I guess. That's something that I wouldn't have really ever been privy to, being someone who works outside of cardiology. Just a couple of things I picked up on specifically from that. They were talking about how cardiac MRI can sometimes be useful to see how much of the heart muscle is still viable prior to choosing an intervention, but apparently it's not as much of a slam dunk as one might hope. It's sort of a controversial thing currently. Dr. Samayoa was talking about how arteries are better vessels to use than veins for coronary artery bypass grafting, which just makes sense, I guess. A lot of times they will take the saphenous vein out of the leg and use that, but it's just kind of common sense, I guess, that an artery would be better to replace an artery with than a vein. But he talked specifically about how it is better because of, again, the chemical messengers and things that you get from the endothelial cells of an artery that you do not get from a vein that end up causing vasodilation downstream. So even the grafted arteries that they put in can end up having positive effects as far as vasodilation on other coronary arteries downstream from them if you use an artery versus a vein. So I thought that was pretty interesting. And yeah, that was the day. So pretty interesting presentations. Always appreciate the doctors doing anything to help get the word out and educate the rest of us on whatever their specialty is. And yeah, I think this is something I'll keep going to annually, other than having to get up early on a Saturday morning. It's pretty painless and not super expensive. So I highly recommend if you're looking for some CE activities here locally next year, keep an eye out for the 2026 Huntsville Hospital Cardiology Update. Thank you for listening. Special thanks to our Patreon supporters. I hope you have a great week, and I'll talk to you later. right, that does it for this episode of Knowledgeable Provider. Very special thank you to our Patreon supporters. If you would like to help support the show for just $5 a month, please head over to patreon.com/knowledgeableprovider. If you're looking for more content, check out our YouTube channel and our Facebook page. Remember, all of those ratings, reviews, likes, follows, subscriptions, etc. really do help the show, so take a second and do those things to help me out. If you have a request for an episode topic or if you'd like to be a guest on the show, I'd love to hear from you. Email me anytime at thekppod@gmail.com. That's thekppod@gmail.com. Thanks so much for listening, and as always, stay safe, take care of yourself, and take care of your patients in that order.